So if we can get to my talk up, that'd be great.
Whose talk is this?
It was the one to follow Dr. Kelly's? Okay. So this is a bit similar to what in case anybody's at the cutting edge, but some different angles to the whole concept. Let's see, I'm having trouble advancing here.
The button on the left.
Yeah. These are my disclosures. So why do we treat port wines to begin with? And when these children come in and consult us? And aside from the cosmetic benefit, because many families and patients themselves don't want to have a vascular birthmark on their face or parts of their body, there is a natural progression of these birthmarks that occur over time. There's a natural thickening. This is an extreme. This is the same patient over a 50-year period. We do see thickening that occurs in many, many patients, but usually not to this degree. I think what you see in the bottom left is more typical of what you might see over a lifetime of somebody with a birthmark. So this is one way to get through that. Many, many years ago, we looked at the data that we had about the medical necessity of these treatments and found that 2/3 of all these patients had thickening by the age of 45. And I think this is pretty consistent data. And this is something that we do see as patients get older. You begin to see the little papules, and they become nodules, and they can bleed spontaneously. So we can treat these babies and when they come in to see us, these children. So it's my belief that early intervention can prevent the thickening that can occur and provide the psychological benefit that one can achieve as a result of the treatments. I do treat around the eye. We do put protective ocular shields in. I use a little tetracaine eye shield. Many physicians and people using these lasers are a little concerned about doing this. I think once you learn, it's something that can be done safely and effectively without injuring the eye, allowing us to treat safely within the periocular area. So you can see here that we can get dramatic changes pre and post treatment. You can see how the eyelids themselves have done quite well. The beauty of this treatment, unlike what we had many, many years ago, is that you don't see textural change, you don't see changes in pigmentation. Sometimes with darker skin types, you can get some hypopigmentation or hyperpigmentation, but you need to adjust your parameters accordingly. This is one patient where we saw at a year. I do have a photograph of her showing a 13-year follow-up. We do see some recurrence over time, but it's my belief that the more clearing that we achieve, the less likely you are to see recurrence. I do advise families, though, that once we get the maximum degree of clearing, maintenance may be required, but not always. And here you can see I'm avoiding the hairline. When we do treat into the hair, you can get some alopecia. It can be long-lasting. Many patients are concerned about this and families, so I generally avoid that area, although you can do it if you need to. As I mentioned in the earlier session, treating the extremities is particularly difficult. Once you get below the elbow, below the knees, the distal extremities are very, very hard to treat. But there is that window of opportunity that you have in early infancy, where if you begin to treat regularly and fairly aggressively, you can get some nice clearing. Now, treating skin of color, you can do it. You have to be more concerned about post-inflammatory hyperpigmentation. I usually lower the energy a little bit. I avoid some of the shorter pulse widths, but you can get significant clearing in the darker skin, as you see here. And I've actually treated patients who are type 6, type black, but I use much lower energy. I'm very careful about the endpoint, looking for epidermal change, and by avoiding that, you can get lightening. It's hard to get clearing, but you can lighten some of these very, very dark or black patients with their birthmarks. One of the issues in treating young children with these port wine birthmarks is the fact that there are some concerns about repetitive exposure to general anesthesia. As these kids get older, it's many times necessary to use anesthesia, but we try to avoid it under the age of 3, primarily based upon this FDA warning that came about a few years ago, where repetitive exposure to general anesthesia may have some deleterious effects. Now, our group had published this paper now in 2019, the largest series to date of young children under the age of 1. And we had rather nice clearing and lightening. And this is, I think, the greatest amount of clearing that had been published to date, -1, or there's an article in the New England Journal that had all patients clearing 100% many, many years ago, but I don't think anyone really believes that's possible. But here you can see many of our patients did have over 75% clearing, and a number of them had 100% clearing. And I think this is something we can build upon with further modifications of the technique. And I think it's also cost effective to treat in the office setting, avoiding the hospital. So it's better for the insurance companies, it's better for out-of-pocket expenses for the patients and families. So this is something that's important as well. Now, many of our families and some physicians and some of the critics of this particular technique of treating these young children are concerned that this is a very painful procedure, and I can't say that it's painless. But Dr. Nelson, who's on the podium here and just spoke, developed dynamic cooling, which is something that has minimized discomfort, but also protects the skin from injury. More recently, we've also been using post-cooling. So right now, dynamic cooling is very, very helpful in terms of minimizing pain. But we did a tolerance study looking at 47 infants less than 2 years of age, no anesthesia other than dynamic cooling, and found that with 2 validated pediatric pain scales used, the procedures were very, very well tolerated. And this is something that was noted by the patients' families and our staff. So basically, the pain scores returned to normal within minutes, and there was a minimal decrease in pain immediately. And what surprised us is that placement of the eye shields did not impact tolerance. Granted, we're pretty good at it. We do this all the time. So there's no real struggle to put the eye shields in on our part. But this does give us some reassurance that, in fact, we're not overly traumatizing these patients, but I'm not minimizing that it's that easy or that painless for these patients. So our conclusion from this is that office treatments without anesthesia is well tolerated. So how early can we begin? I'd like to go from the hospital to the office. If I can see a newborn a day old, that would be ideal. The earliest to date that I've treated was a preemie who was delivered came to my office 10 days before their due date, and that patient did very, very well. More recently, and this will be discussed in later detail by Dr. Tao from our group, where we looked at 10 patients and we did weekly treatments. So early on, we were treating every 2 or 3 weeks, but we found that if we treated on a weekly basis, using larger spot size, we had more rapid clearing, more complete clearing, allowing for a very easy treatment or relatively easier treatment compared to others. What was interesting, you can see the results here. Look at the control in the hairline compared to the face. Dramatic clearing here. 1 month, 4.5 months, weekly treatments, dramatic clearing. And this is the immediate post, using relatively high energies with a larger spot size, no purpura. So it may be that the fact that we're able to treat without the purpura interfering has allowed for a dramatic change. And also, as I mentioned earlier, the ability to treat on the body and the extremities is much more effective if you begin very, very early and adopt this weekly treatment session, a technique. The dynamic cooling, the cryogen spray before each laser pulse, we're now using this with post-cooling as well, and that minimizes the discomfort even further, making it a much more tolerable procedure for patients. The families are giving us very, very positive feedback in terms of the discomfort. So here's the patient that I had showed earlier with the 1-year follow-up, and here she is, a photograph 13 years later. We don't see that in all patients, but we do see this in many. Again, maintenance treatment is often required. So the bottom line is you can treat young children. Earlier the better. From the hospital to the office setting, I think would be ideal. This can be done safely, effectively. You can minimize discomfort by using the cooling techniques and treating with larger spot sizes, which is something that will be readily available in some of the technology available today and others that will be available in the very near future. Thank you for your attention.